Welcome to this IHF program. My name is Yohei Ohno, interventional cardiologist from Tokai University Hospital, Tokyo, Japan. And today I am delighted to be joined by Frederik Verbrugge from Belgium. He's a heart failure specialist. So welcome, Frederik.
Nice to be here.
Thank you. So today we are going to discuss about the optimal timing of intervening patients with secondary mitral regurgitation with symptomatic heart failure. So as we know, the new guideline has updated 2025 for European heart guidelines. So could you tell us a little bit about what has been updated in this guideline?
Yeah, so we have a new 1A recommendation for mitral TEER in patients with ventricular secondary MR. So this is important. They made a distinction between ventricular and atrial. So this means to reduce the risk for heart failure in patients that have been optimally treated. Optimally treated means we have the 4-pillar therapy aboard. We have considered things like CRT resynchronization therapy. Atrial functional MR, we don't have that many evidence. We don't have large trials. We still need RCTs there, but there is to be a recommendation there.
Mm-hmm. So now we are talking about the optimal timing of intervening patients. So what is the definition of optimization of these patients?
Yeah, I think this is still work in progress. There is optimized treatment, but it doesn't say exactly how much efforts you should do to optimize this. So what I do think is important is that we have those guideline-directed medical therapies aboard, which is sacubitril valsartan, beta blockers, MRA, and SGLT2 inhibitors. Mm-hmm. I think this is the first step, bringing them aboard, looking whether there is an indication for resynchronization. A synchronous ventricle means also atrioventricular synchrony, so we like to have our patients also in sinus rhythm. More and more there's an emphasis on early rhythm control. And then I think a second step, which is often forgotten, is adequate decongestion. So things that might help us there is we have a lot of advanced options now. There's ablation in heart failure, there is mitral intervention, there's also pulmonary pressure monitoring. So I think going back to the cath lab, doing a right heart cath, checking whether the patient is properly decongested, and maybe considering also pulmonary pressure monitoring might give you a good idea of the hemodynamics and see if you control the hemodynamics well, and there is still an important MR, or the MR is making things difficult hemodynamic-wise for your treatments, then it's certainly the time to intervene.
Exactly. I totally agree with your strategy. Decongestion is absolutely the key. And as for interventional cardiologists, I always try to optimize, as you mentioned, the patients before intervening mitral valve with mitral TEER technology. However, in some subset of patients, due to low ejection fraction, low output status, patient might suffer from reduced blood pressure, that we cannot up-titrate those medications because more or less these medications could decrease the blood pressure. So in that kind of clinical setting, we consider to a little bit early intervention of mitral TEER, which increases the cardiac output and eventually increases the blood pressure. Then we are able to up-titrate those medications. So is there any data or recommendations how to manage patients after mitral TEER?
Yeah, so this is a great question. I think it's very important to realize we should optimize treatments first, but also when we do a procedure, actually the device can also enable better treatment. And I get this point very well. I think, again, hemodynamics are very important to understand. Sometimes when you're really in that optimization phase and you have a patient with borderline low output, sometimes you cannot go with the beta blocker first, and it might impair you for up-titration of other treatments. So there are patients where you can easily up-titrate all four. There are patients where you should be more careful, more hemodynamic guided. But once you have done this, sometimes you're just stuck and you shouldn't wait too long. An important concept for me is that the atria, they are the canary in the coal mine. We don't want the patient going into permanent AFib.
Yeah.
We don't the atria to remodel to advance. We should be with our interventions before that. And sometimes it is the case, as you said, that the hemodynamics are by the TEER so much improved that then we can optimize again the therapies. And this is something we should be pay a lot of attention to. So I completely agree.
Thank you, Frederik, so for your great insights. So today, even with this discussion, we learned a lot. We learned that the new guidelines have updated 2025 ESC guidelines, Class A indication for ventricular FMR, secondary MR, and Class 2B indication for atrial secondary MR. How to optimize patients? Obviously, we have 4 strong pillars. So try to achieve decongestion using these 4 kind of pillars. Up-titrate as much as possible, but in case of low blood pressure, low output status, we can early intervene mitral valve using mitral TEER. And don't forget to up-titrate after the mitral TEER intervention. So thank you for joining, Frederik. So hope to see you soon.
You're welcome.